So this is a quick look at the local enhanced clinical effective service. I'm not going to go through all the paperwork, just looking at the elements for searches that we've made to help. So there's a search looking at yellow card submissions, and then the searches help look at high dose opioids. It is worth noting there's a very useful appendices for this, and in this it's got various searches you can use if you want. I've done slightly different ones for mine just to sort of help look with oral equivalents. And so if I'm looking at my patients, there's the export to look at those, and I'll show you how that looks when you export it to Excel and save it to your dashboard. I've just had to hide patient identifiable features, and what it'll show you is the opiates, their dosage. I have slightly separated out oral morphine because whilst the slow releases are likely to give you an idea of daily amounts, the trouble with the morphine oromorph or morphine sulfate or Sevrodol is that you probably do need to know how many of those they've had issued in the last month. And I'm afraid that there's no easy way to try and find your 120s. You're going to have to go through these. So, for example, this individual is on 50 of Zomorph daily, 100mg daily. They haven't had any of their morphine in the last month. They're borderline, I suppose. If they had their morphine and they'd had 300ml of morphine, then what you'd find generally is that's 600mg divided by 30 would be 20mg a day, which would push this person into the 120, but they don't qualify for that this month. Again, the appendices are very good. They've got a table for oral equivalences so that you can look and say, okay, people on long tech, trans tech over 70 are already over the 120, and you'll have to go through and find your patients. Of mine, I think there's about 7 or 8, but there's no easy way of finding the ones that are over 120. And so if I look through these and see from another example, they have patients like this person here who's on Zomorph. They're on 40 twice a day, which is 80mg. What you can see is they've also had 2 issues of oromorph, so they've had 3 issues of oromorph. They've had 600ml, which is 1.2 or 1200 milligrams of morphine, which means they're having equivalent of 40 a day, in addition to the 80 here, which means they do count as total of 120 daily. And there's just no easy way of doing this, I don't think, other than just getting them out into the chart and looking. So again, there's a patient here, 14079. We can see that they're already on Zomorph 60 twice daily, so they're already on the 120, but they've also had 1, 2, 3, 4, 5 issues of morphine, and that's 200ml a time. So there's 1,000ml or 200mg of morphine, which you divide by 30, which I guess is around 33mg a day. So their total is 120 plus 33, which would be 153. And this guide here talks a little bit about how to work out, they show it in their data collection sheet, how to work out daily equivalences for Minnie Mouse. So I'd find my 7 patients in my practice that are over 120, and the idea is that this asks you to put a little tag in the patient's records. So it asks you to add an alert in EMIS, and I think most of us are very familiar with how to do that. It's fairly straightforward. You just open the bar. I can't do that because it shows patient identifiable information. So my 7 patients would have this little alert put in, which is the do not increase current opioid medication alert, and let's just think that warning came up when we load records, add drugs and issue drugs, which I guess is only for those limited number, and I guess some practices have more than others. We have searches that look at antibiotic prescribing over the past year. That's also part of the national prescribing indicators and do come under the assurance framework searches here, where there's a few more searches actually looking at antimicrobial stewardship if people want it, and there's a brief summary of that in another video. But if I look at this one, I do have the prescriber, the antibiotic indication list report, and you can view that one. There's nothing potential identifiable, but the thing it'll show you is who's issuing what and for what, and you can export that and play with that in Excel. It gives you an idea of who is the highest prescribers, etc. We'll also have to do an audit for 3 months prescribing trimethoprim. Now, the idea is that if you're going to give trimethoprim to anyone over 65 for UTI, it has to be based on a culture. So they're suggesting that this audit is done at 3 months in the year, July, August, September preferably. I've had a word, we've got, I think, slightly higher prescribing I'd like to see in trimethoprim in that group. We've had a word with the doctor involved, because we can see who likes prescribing from that list again, and said, hey, we need to not prescribe trimethoprim in that group. And when we go to our audit, July, August, September, I expect the numbers here to be quite low. There is no easy way to do the legwork on this one. If we go to the appendices, and I'll scroll down to the trimethoprim, we are going to review up to 50, although hopefully after my pep talk the numbers for my practice will be quite low, and we'll look to see, has there been a culture in the preceding 6 months that shows that they were sensitive to trimethoprim. And what we're going to have to do then is fill in this Microsoft Forms page. If I show you this, and the Microsoft Forms page will ask you to put your cluster, your practice, and how many were given trimethoprim. When I run this audit in October, November, I expect this to be very small, and I expect that it's only going to be given if there's a sensitivity on the culture, and hopefully this number will be 0 and this number will be 0 and the total will be there, and I'll put those in. The reason I say that is that the payment for that depends on 90% of those trimethoprim prescriptions having had a culture that shows they were sensitive to trimethoprim, which is quite a high target. I've been very clear in my practice, we are only prescribing if there's a culture that says we should. And the same for ciprofloxacin. The audit for this is a little bit more meaty in the appendix, and you're going to have a look at each of your Cipro prescriptions. This is just the same thing as we're doing online, but we'll have to do it as a paperwork thing as well. And again, it's going to be transcribed into that Office Forms sheet. We're going to have to talk about it, so I think we can talk about how the initial review, we thought there was one doctor in particular who had to change their practice, and then same for Cipro. My practice is quite low anyway, but again, for every Cipro prescription you're going to have to look to justify why, and actually the Cipro one is a little bit more meaty because we're going to have to fill this in, and you can drop down to say, was it for pyelonephritis, acute prostatitis or other, and I think you have to give a reason you gave it. You're going to have to say, was there a culture, and was it recommended, and if there were other antibiotics, you have to justify why you didn't use those, or why you discuss it with a microbiologist. Otherwise it'll be counted as inappropriate. Now this one has again a 90% compliance that they'd like to see. So if you're going to prescribe ciprofloxacin, you don't want any inappropriates. If, say, you had a small sample like mine of 3, you'd have to make sure that all 3 of them were appropriate. So again, we'll be running this audit later in the year, and I'll be making it very clear to my clinicians, please only prescribe ciprofloxacin where it's an appropriate indication and there is a culture, and that culture, there isn't another antibiotic we can use. So I might show you, well, I won't show you an example of that, but certainly I've looked through mine and I can see where there is a culture. It's very clear that ciprofloxacin is the thing advised by the microbiologists. We then have to choose one of 2 audits looking at, so there's a bit of a talk about the educational things we'll have to go to, and we'll also have to look at 2 audits, one either at anticholinergic burden and the other either looking at gliptin use. I think at this point it's worth pointing out that anticholinergic burden will fall under 2 other things this year, which is it will fall under the assurance framework prescribing safety modules, and it'll also fall, so it falls under anticholinergic burden here, PS12 assurance framework. And from what the LMC circular told us is that the quality improvement project will also be looking at prescribing safety. So in some ways I would encourage looking at anticholinergic burden. I have put searches in for gliptins. The gliptin search looks for those people who are well controlled on acetagliptin already, but they're not on, they're well controlled on the gliptin, but they're not on sitagliptin. Do we switch them? Those who aren't well controlled, and perhaps we should review, take away the gliptin and reconsider. And search is just looking to see, hey, are they on the appropriate dose for their EGFR? I would encourage people to consider the anticholinergic burden one, simply because you're going to, potentially need to consider it prescribing safety and assurance framework anyway. You can use Audit Plus to find your patients who are on medications for high anticholinergic burden scores. We have created a table for this, and I can show you this. Now I've taken away name and date of birth, but it's 3 columns. One will show you medications that have got an ACB score of 1, 2 and 3. And so you can look through your patients and say, well, this patient has an ACB score of 4 because they've got 1 drug there, 1 drug here. This patient, same, score of 4, these score 3. This patient here would score 3. This patient scores 3. This patient scores 3. These patients scores 4. Not a lot of patients score 5. So when you go through the pages here, you can see a patient who is on Neditol, which scores 2, and imipramine that scores 3. So this patient scores 5, so needs perhaps a more urgent review. And you can see actually they're on Neditol and paroxetine and imipramine, so they would actually score 7 here. And I guess there's different ways you can use this information. We can export that table into Excel, have a play with it, perhaps identify the patients on amitriptyline and warn them of anticholinergic burden and the symptoms of anticholinergic burden, and ask them if they'd like to either stop or discuss their medications. And it may be just a quick way of stopping some of them. I think the other thing that we've searched for are those with ACB scores higher than 3 with falls of confusion, which is one they'd like to prioritise. When you do open these patients, it's worth saying that they already have some of the alerts that we've put in place for the assurance framework. So for example, I'll show you this patient here. Now, because their ACB scores 3 or higher and there's been falls of confusion coded, it's flagging up the warning. This doesn't warn if there's just an ACB score of 3, although there is also a little alert for that. And if I open up this patient's records, you can see it's flagging up assurance concern. Now you can't see the boxes where I'm hovering, but it would say the anticholinergic burden scores over 3 and there's a recent history of false confusion. When you hover over the ACB score, again, you can't see it, but it will tell me that that's for mirtazapine and tolterodine. So it does tell you that the drugs that are triggering that score. There's also search looking at ACB scores of 5 or more. It's worth saying the slight difficulty with that is that if there are 2 drugs in the same column with 2 different doses, they will flag as scoring twice. What I mean by that is something like this patient here. So I know, for example, this patient has an ACB score of 5 or higher, so they're being pushed into the that is showing ACB score of 5 higher, high risk prescribing, and it's telling me that it's because they're on sertraline and olanzapine. Now, what I know is that the olanzapine here is counting twice because there are 2 different doses. There's a 2.5 and a 5. If I go to that table from before, what you can see is that's this patient here where the sertraline is an ACB of 1, olanzapine is an ACB of 2, so technically her score should be 3. I guess you could argue that that she's on quite a high dose of olanzapine and it's encouraging the reduction in dose, but it doesn't quite correlate exactly right always with scoring, but I'll show you another patient that does. So this gentleman is pointing out there's ACB scored higher than 5, and it's telling me it's because of Neditol and imipramine, and you go down to this list and you'll see that there's Neditol and imipramine. If we go back to that table, you can see we would have picked up a score of 5 from the table because the Neditol's in the 2, the imipramine's in the 3. He's also on paroxetine, which puts his ACB score up to 7. And I guess you could run this search with relative dates of March this year. Again, you would just say, okay, we can run that with advanced options and run it to relative date earlier in the year and later in the year to see whether your numbers have gone up and down. We could run that table at the beginning of the year and look again at that table later in the year to see if those patients have lower ACB scores. There's various ways of playing the data on that one. I think possibly my searches there are going to be easier than pulling in searches from Audit Plus and then trying to run patients through MediCheck. This is where you have to put your patients' medications one by one into this list, and it'll give you a score, which I have to say I don't particularly like. I know the enhanced service does talk about prescribing quantities of 28 and 56. I think this data will be given to us from shared services. I think we can get access to that. I don't. And then for dispensing practices, it's suggesting that we look to make sure that if we're not going to change our patients 56 days, we should at least look for those who are perhaps on weekly and review them and code them with one of these codes here. So we have created a search just to look for those where we suspect they are on 7 days, and I'll show you this. So again, I've slightly altered this, so I'm not showing anybody's patient identifiable details, but what we do have here is it just shows those where the quantities are 7 or 14, and ideally by the end of this year we'll have one of those codes from this enhanced service here for each of those patients. So we will have got those 56 and look to show that yes, we have put the code 9C07, I guess, is the one that we will use in our practice just for convenience patient medication advice, so that we will have that by the end of the year. And that's just a very quick run through. I could spend an awful lot longer going through it, but I think it's useful to show as a bit of a guide. I think the appendices are very good, and it's useful to learn how to import the searches they have. I think the opioid search is slightly different, but equally very good. I guess it's people are perfectly welcome to use mine or that one. Sure.